we'll be moving on to our next debate. So we've got a debate. We all know that for early stage lung cancer, for young fit patient, surgery is the primary treatment. And for medically inoperable patient, we do offer them stereotactic radiotherapy. But if you look at the outcome, surgical cohort always show better outcome because their cohort always contain a younger, fitter patient. On the contrary, a radiotherapy cohort always have older patient with multiple comorbidities. So they end up showing poorer outcome. And there has been trials comparing head-on SBRT with surgery with a conflicting result. So here we are to discuss about it, whether SBRT is equally effective treatment for stage 1 non-small cell lung cancer compared to surgery. So bear in mind, these are medically operable patients. That's the topic of discussion. We have Dr. Rajkumar Srimali for the motion. Dr. Srimali is a senior consultant clinical oncologist working in Arden Cancer Center, University Hospital, Coventry, and Warwickshire, NHS Trust, UK. Dr. Srimali has numerous publications in national and international peer-reviewed journals. He has been part of many national and international clinical trials, and Sir has pivotal role in setting up lung IMRT and SBRT services in Eastern India. Sir has always been my teacher and my mentor. I'd like to welcome Sir. So over to you, Sir.
Thank you, Animesh. Trying to get this started. Can you see my slides?
We can, yes, sir, we can see your slides, sir.
Okay. So yes, thank you, Animesh, for your very kind introduction. SABR, SBRT or SABR is equally effective for stage 1 non-small cell lung cancer compared to surgery, and I'm going to speak for the motion. It doesn't seem to be moving. So I believe we all know what SABR is. It's extremely hypofractionated radiotherapy delivered in a small number of fractions, BED more than 100 gray, and proper accounting for tumor motion, precise contouring of tumors, and precise dose distribution needs to be carried out, and very accurate dose delivery, either using volumetric image guidance or fiducial based. We all know what stage 1 non-small cell lung cancer is. So before we start off, there is a saying that you need to keep your, well, the saying goes you need to keep your enemies close, but we'll say we need to keep your opponents close for this because we don't have any enemies. So what is the status of surgery? Well, surgery has been around for decades now for stage 1 as well as stage 2 and even 3A lung cancers. And there have been many studies published. It comes with a 30-day mortality and a 90-day mortality. And there are numerous reviews of surgery published by the surgeons that confirm the 90-day mortality. To be between 5 and 10%. And although lobectomy is the standard of care, some patients end up getting bilobectomy. And although it is very rare for stage 1s, some patients also end up getting pneumonectomies. So up to 20% of patients who are being considered for surgery, they're either not able to undergo because they are not fit enough, and the anesthetist would not allow the surgeon to get near the patient, or the patients refuse when they find out about other options. And the complication rates are not trivial in older patients with high comorbidity scores. And again, after receiving surgery, up to 5% patients will have chronic disabling pain syndromes. And then the surgeons talk about tissue diagnosis. So what is the reality? Well, excellent local control for surgery and SABR makes it irrelevant. Molecular markers are not useful in stage 1. And interestingly, I have seen over the last few years, once the surgeon will push for tissue diagnosis, but once the patient develops a local recurrence, if it's beyond 2 years, they keep arguing it's a new primary. And if the MDT agrees that, then previous histology is not something we can use because if it's a new primary, it's a new primary. And again, if somebody gets a recurrence, tissue diagnosis can be obtained at that point, or a salvage resection could be carried out. What is the status of SABR? So the outcomes from SABR, again, they have the head-to-head comparison in randomized studies have not been successful because patients not sufficient numbers of patients have been accrued to these studies, but in single arm and prospective studies as well as retrospective series, the outcomes are actually comparable to surgery. 5-year control rates around 90%. So it is well established in patients who are medically inoperable, which means they are inoperable because the patients are not fit for surgery. It is recommended by several international guidelines. So that bit is established. Now, coming to operable patients, which is the topic of this debate, randomized control trials have been set up, and there were 4 trials. All of these have failed to recruit patients. Why? Because SABRE is a radical change from the established standard of care at the time, which is surgery, the contemporary standard of care. And again, both these options have been available to patients. So patients can actually choose between surgery and radiotherapy. And most patients will have some bias of they either want a surgery or they don't want surgery or they want radiotherapy. So if these options are available, they don't like the idea that this will be chosen randomly for them. And at least in Amsterdam, the thoracic surgeons who helped set up the Roselle trial eventually failed to participate or recruit patients because a service optimization review was run at the same time, and there was a risk of reducing the surgical service within the country. So Joe Chang from MD Anderson carried out a pooled trial data analysis. It's a small number of patients. It's 60 patients, 58 patients, and 1-year survival with SABRE was actually higher than surgery in this pooled analysis. And 3-year overall survival was also superior. So when we see this, the survival curves, SABRE is actually higher and surgery is dropping. Now, this is very provocative, and this is counterintuitive because we are groomed to believe that an operation takes the cancer out and shouldn't be any worse. So there was small sample size and there's a shorter follow-up. So this data has to be interpreted with caution. And also very few events occurred. The follow-up was limited, and the survival in SABRE was better than expected in these 2 studies. And again, salvage surgery is possible in SABRE failures. So that can have an impact on that. However, this study actually confirms the equipoise that either of them are not worse than the other. So where are we now? We should recruit more patients in studies. Now, this is an important concept for radiation oncologists to understand propensity score matching. And this is something that in the last couple of years, I'm reading more and more about. So it is a useful method where randomization is not possible, either logistic reasons or ethical reasons. And the researchers use statistical techniques to construct an artificial control group where the treatment characteristics are matched. And the propensity score matching has actually helped the SABRE cause. So after the failure of the STARS trial, the team at MD Anderson then carried out a single-arm prospective study where they took they actually maintained. Sorry. Yeah. So it was a prospective study where additional 80 patients were recruited, and then they identified comparable controls from the same institution, from their own registry. And this was designed to test a 3-year overall survival. And because the MD Anderson has a high volume thoracic surgical units, they actually did not have any mortality or significant morbidity. And in this study, kind of getting stuck. Yeah, so with a median follow-up of over 5 years, the overall survival with SABRE was impressive. It was actually comparable to surgery. There was no significant difference. There was a higher rate of regional recurrence, which means nodal recurrences in the SABRE group. And again, we have to be mindful that surgical patients have nodal upstaging. So 10% of surgical patients, if they carry out a mediastinal nodal resection, they'll find node positivity, and then they are then moved from stage 1 to a different stage. So that was that. Reassuringly, this study also showed that people who get isolated regional recurrence following SABRE were effectively salvaged with subsequent treatment. So the challenges with randomized control trials have been ongoing. A few studies have failed, few are ongoing. This is a retrospective data from a single large UK center, 468 patients, some with surgery, some with SABR. And what this study showed, this is real world data. So what they showed was there was no there was no difference in cancer specific survival and combined cancer and treatment related survival. So these are Kaplan-Meier curves. The first curve where surgery is shown to be better than SABR and standard radical radiotherapy. And with the second one, we are looking only at the cancer specific survival, and the lines, the curves for surgery and SABR are kind of overlapping. This is more of the same, is essentially the causes of death. So systematic review is the best evidence in the absence of randomized trials, and this is a large systematic review with over 3,700 patients for SABR and over 2,000 patients for surgery, and the 2-year survival were comparable. The SABR was equivalent despite the comorbidity. And the criticism would be that this is non-randomized, there's a risk of bias, the surgical groups are an earlier group, there was stage migration. But on the whole, this confirms the equipoise, which is the topic of this debate. Meta-analysis, another meta-analysis, 40 studies for SABR, 23 studies for surgery. Median unadjusted results were not comparable because there was a significant difference in populations between the patients who underwent SABR and surgery. But when the patient profile differences were adjusted, SBRT was found to be non-inferior with respect to survival. Population analysis, again, proportional hazards regression and propensity score matching was used to compensate for confounders. And with well-matched cohorts, sublobar resection was worse than lobectomy, but SABR was comparable to lobectomy. 90-day mortality was 4% for lobectomy and 1.3% for SABR. And again, the SABR patients are likely to be in their 80s, the females, higher comorbidities, some require supplemental oxygen, poor performance status, they're more likely to be PET staged, and also when they're treated, they don't actually get mediastinal staging procedure in the population analysis, but we know that EBUS is now widely used. Subsequent SEER study, again, no difference in 2-year survival, 70% versus 68%, no difference in local control. So differences in the groups, the less invasive lymph nodes with SABR, no lymph node dissection, could have been harboring occult nodal mets. With surgical cohort, they get more therapy, shift in stage, and then subsequently, because of shift in stage, adjuvant therapy is also a possibility. Economics-wise, the actual cost of SABR is about half of lobectomy. So lobectomy could become cost-effective only by producing more quality adjusted life years. But by and large, SABR is actually cheaper and doesn't require the same kind of infrastructure. So the surgery, the goalposts are shifting because the sublobar resection is now creeping in. While segmentectomy is a surgical procedure, wedge resection isn't. So is SABR equivalent to sublobar resection? This is a publication from the Christie at Manchester. There's no randomized data. Prospective studies were compared, and 1-year survival was similar between SABR and sublobar resection. And 3-year survival was higher with sublobar resection. So what do the patients want? So there was a study that was published a few years ago that was carried out over 102 patients, of which 89% of the patients participated, and nearly 80% patients said they were more satisfied with SABR than with surgery. And this is possible because of the 102 patients, 41 patients had prior surgery. And of those patients, 89%, they said that they would have rather had SABR even earlier, but they didn't know that that option was available. So it is important that the patients are informed. So basically, this was the question. If you can decide now, would you rather have SBRT in place of your surgery in the first place? And up to 90%, nearly 90% said yes. So quality of life, the red line for SABR is higher for the global health status, whereas the blue line for surgery is higher with dyspnea score and pain score. So this is straightforward. Now, both of these treatments result in decline in lung functions. So with lobectomy, the decline in lung function is up to 16%. With sublobar resection, segmentectomy up to 11%. With SABR, it is up to 6%. So, and with the surgical, the patients had good reserves, whereas with the SABR, we often have patients with poor lung functions. So in spite of that, we had a less decline. So what's happening in the real world? Well, this is a publication not very long ago, 2018, and they have looked at data from 2004 to 2012. Radiotherapy increased from 13% to 29%, surgery declined from 76 to 61%. And that's a different study with similar graphs. Yes, there is an argument that very conformal radiotherapy with SABR causes very conformal fibrosis, but with the use of PET in follow-up, I think that problem is being looked at. So summarizing, primary tumor control rates are around 90% or more. With SABR, 3-year survival is comparable to surgery, outcomes are widely reproducible, and SABR is not dependent on high-volume centers. It's very convenient, outpatient, no need for anesthesia, no need for hospitalization, safe and well tolerated even in elderly and frail patients. There is less decline in lung functions. There are no issues of chronic disabling pain syndromes. The 30-day and the 90-day mortality with SABR is close to 0. There is minimal impact on the patient-reported quality of life because that is clearly favorable with SABR. There is less decision regret. So if a patient has had surgery before and SABR subsequently, they would have rather had SABR in the first place. Now, this is a question. Despite the local risk of local recurrence and occult disease, we could improve on surgery. Now, organ preservation is widely used in larynx, bladder, prostate, breast, anal cancers. So I think we need to at some point propose a trial where patients get upfront SABR with reservation of surgery for salvage, and VATS could be used. So that should be the way forward for a prospective study. So summarizing, safe and effective, excellent local control, never been compared to surgery in a fair manner. Our randomized control trials are necessary, but they don't seem to recruit. So we should have a trial with upfront SABR followed by salvage surgical resection. Until then, we can argue that it's equally effective. Thank you.
Thank you, sir. Thank you for the elaborate talk. I think we've got a question from the audience. I think Dr. Jackie Agarwal is in the delegate. So, sir has asked, which patient would you refer for surgery rather than SABR?
In the MDT within the NHS, we don't refer patients for surgery. So the patients are discussed at the MDT, and often if they are eligible for both, they get given the option for both. Clearly, patients who have stage 1 lung cancer within 2 centimeters of the main airways, currently SABR is not routinely used within the NHS for central disease outside of a clinical trial. For everything else, if it is feasible, we tend to offer SABR, but we tend to use what is called a Herder score. So everyone gets a PET scan. So either they have to have a Herder score with the probability of cancer more than 80% if they don't have histology, or they have to have a clearly growing disease on 2 consecutive CTs. And then we can offer SABR. Some patients will opt for surgery, others come for SABR. Okay. There is no constraints in terms of lung function tests. Yes, if somebody has extensive interstitial lung disease, then we don't tend to use it.
I think we should move on to our next debater. We've got Dr. Robin Thambodorai. So Dr. Thambodorai will be speaking against the motion. Sir is a senior consultant, thoracic and GI surgeon, Tata Medical Center, Kolkata. Dr. Thambodorai has been one of the lead thoracic surgeons in Eastern India. I'd like sir to take the proceedings, sir. Over to you, sir.
Can you see my slides?
Yes, sir, we can see the slide.
So it was good to see Raj after a really long time. Raj used to be my colleague at Tata Medical Center, very passionate radiation oncologist, but unfortunately, I'm going to have to disagree with him. Now, I want to start by saying that I have absolutely nothing against radiation therapy being offered as a primary source of treatment. But before I start, I just want to give you a little bit of background. This is actually my background with regard to this debate. The first time I heard this debate was in 2009, and most recently in the last month. Actually, that should have been 2022. So clearly, if we have been debating this for over 10 years, then there is a problem. And the problem is that there is whatever literature we see, there is a lack of robust evidence in favor of SBRT. Then the other thing that Raj referred to, and the issue of occult mediastinal nodal metastases, SABR does not address this question. SABR cannot be given to all stage 1 tumors, depends on the location of the tumor. Further, and I've looked at this in literature, there's no actual uniform definition of what constitutes local control following SBRT. Third, second last, distinguishing radiation-induced lung injury from recurrence can be very challenging. And most importantly, and which may not be a problem in the UK or in many developed countries, but this requires intense follow-up. In a center like ours, where we get patients from all over Eastern India, Northeastern India, Bangladesh, Bhutan, it can be challenging to have patients go through this kind of follow-up. Just refer very briefly to 2 meta-analyses, Chen et al., 2018, combined results of 16 propensity score studies comparing surgery and stereotactic ablative radiation. Overall survival favored surgery. Jatilo et al., 2019, 792 patients, more than 65 years of age with clinical stage 1, underwent VATS lobectomy or SBRT. Propensity matched comparative analysis, median overall survival rates were significantly better in the surgical group than for SBRT. Now, we looked at, Raj looked at some of the trials that were tried and which didn't work. And I'm just going to refer to 4 trials, 3 of which are ongoing. And I think these may actually answer the questions. The VALA trial in the US, the Veterans Affairs hospitals, where they're going to be looking at operable stage 1, less than 5 centimeters, peripheral or central. They're going to be stratified stage A, 1A versus 1B, central versus peripheral, and then randomized to lobectomy or segmentectomy and stereotactic radiotherapy. And the endpoint is going to be overall survival. And this trial does not permit wedge resections, which are not really a cancer operation. They estimate that they will enroll 670 patients. The estimated primary completion date is going to be September of 2026, and the study completion date is going to be a year later. No interim results have been published. Then the Stablemates trial, again in the United States and Canada and North America, estimated enrollment is 277 patients. Study is to be completed in 2024. The primary outcome, again, overall survival. Then there is the PostLive study in China. It's a small study with an estimated enrollment of 44 patients. Primary outcome measure is going to be loco-regional control with overall survival, among many others, as a secondary outcome measure. And then I'm just going to go back to the Sabertooth trial in the UK. This was not really a trial to see whether they can compare SABR with surgery, but to see if they can actually do an RCT. It was more like a pilot study, as far as I can understand. They wanted to enroll 54 patients, 3 patients a month in a 7 to 21 month period. And it was supposed to be completed in 2017. The primary outcome measure was the achievement of a steady state of recruitment. So what did they do? 318 patients were considered. 106 patients were assessed as eligible. Only 24 patients were randomized. 14 to SABR, surgery 10. Only 15 patients underwent allocated treatments. SABR 12 and surgery 3. And the conclusion from this trial was that an RCT on this cannot be performed in the NHS. But the trial that I'm most looking forward to is this Canadian trial by DiPalma, the MISSILE trial. It aims to enroll 40 patients. This is a slightly different trial because what they plan to do is they're going to give SBRT, and then all patients 10 weeks after completion of radiation are going to undergo surgery. The interim results were shared at a conference in Toronto and published in JAMA Oncology in 2019. And they showed that the pathological complete response rate was only 60%. That means 40% of patients still had viable tumor. This study is due for completion in September 2022. Incidentally, the combined approach had toxic effects comparable to the series of surgery alone, and there was no perioperative mortality. Further studies are needed to evaluate this combined approach with surgical resection alone. So in conclusion, I still stand by the fact that SABR is appropriate for medically inoperable patients, patients who decline surgical treatment, patients who do not have access to surgical services. As knowledge and technology advance, SABR may have a more prominent role to play in the future. But in today's date, to say that SABR is an equally effective treatment does not comport with the currently available evidence. Thank you.
Thank you, sir. Thank you for your presentation. I think we've got a question from Dr. JP Agarwal, sir, to yourself. So, which patient you will refer to SBRT, refer for SBRT rather than surgery? I think you have answered the question. If you just
yeah, so I mean, it's not just for stage 1. We discuss the definitive radiotherapy or chemoradiotherapy option with all lung cancer patients. Patients who I would definitely not consider are patients who would be medically inoperable, which means don't have very good lung function, have multiple comorbid illnesses, patients who you don't think can withstand the stress of a surgical endeavor.
I think we'll have 1 or 2 comments from Dr. Srimali as a rebuttal and yourself, if time permits. So, Dr. Srimali, sir, if you're there, any rebuttal comments, sir?
No, I think it was a good debate. I think we've said the same things. We have talked about the trials that have not recruited. Until we have a randomized control trial, it is hard to, we can keep arguing until the cows come home.
I think Dr. Srimali, yeah.
I'd just like to make 1 or 2 points though. While a lot of this mortality data has gone back in time and looked at large numbers of patients, these things are actually changing with time. I can tell you that in Tata Medical Center, we have a mortality rate of less than 1%. Okay. And we do some pretty old patients. The oldest patient we've operated on was 83. Okay. And so mortality rates are not so bad. And the other thing, with the advent of minimally invasive procedures, although we don't do them where I am, but the issue of pain is slowly going to become a thing of the past with VATS lobectomies, robotic lobectomies, although, maybe many patients won't be able to afford them. But pain as an issue is no longer, we don't really see patients with chronic disabling pain syndromes.
Yeah. Okay. Now, what I would say is we are working in different practices. I agree. The surgeons at Tata Medical Center are very sensible and are not as aggressive as some of the other surgeons I have seen in my practice. But I have seen aggressive surgeons, and I have seen morbidity and mortality. I have seen people canceled from surgical lists because they had a PE the night before or 2 days before. I have seen people go into MI in the post-operative period. I have seen people who have had 2 SABRs 3 years apart and have had a 3rd lesion. So there is a limit to how much surgery somebody can get. So I think there's as the services evolve, as the services mature, and as the survival improves, we will have patients who will at some point have multiple modalities of treatment. And there are people at different ends of the spectrum, people who are very aggressive and a bit maverick. So yes, I agree with Robin. The surgical outcomes at Tata Medical Center is very good, but I can't say that same is the true for everywhere. And I have seen some of these morbidities and mortalities, and in the mortality meetings, I've seen cases discussed. So it is not a thing of the past, but yes, that's where we are.
But I think
1 comment, sir. Dr. Srimali has all.
I'll just make one comment. Okay. In the future, I think I find this missile trial very exciting, combining SABR with surgery. Okay, and it may be even better than either modality alone. I think we should wait and watch.
Dr.
You
Shimali
saying,
has mentioned he's not willing to treat patient with SABR who have got interstitial lung disease, particularly the fibrotic pattern, the UIP, or the
severe UIP.
So, any thoughts on surgery to this patient, ILD patient?
Yeah, so we've done surgery on ILD patients. So we don't go so much by what their baseline pulmonary disease is. We go more by their pulmonary function. So they need to have a really good assessment of fitness. If they meet that criteria for the assessment of fitness, we've actually done lung resections in patients with interstitial lung disease, and they've done pretty well, and they're still on follow-up. Okay, but obviously it's not for all patients. It's only for those who meet a pulmonary function fitness criteria.
Yeah, any patient with more than mild to moderate interstitial lung disease, we actually push for surgery if the lung functions allow. So yeah.
I think we have to conclude here. We are running behind time. So we'll move on to the next session. Thank you, sir, for the debate.